Hi, guys. This is Dr. Hine again for the SimKid podcast, talking about a topic that is so near and dear to my heart. It's just do what I do. It's teaching procedures to medical professionals. Now, we at SimKit, we teach procedures all day, every day, but we don't really talk about how to teach procedures. Now, whether you are an attending who is responsible for onboarding new attendings or remediation when there's a bad outcome, if you're teaching medical students or residents or APPs, many of us are teaching procedures to ourselves, to our colleagues, to other staff members. And so knowing how to do this, even if you're not a medical educator, is such a valuable skill that it's worth just having a conversation about. And many of the times, what happens if we don't prepare, if we don't do these types of learnings or thinking about things beforehand, we just say to someone, I'm really good at reducing shoulders. Just do what I do. Watch me do this central line. And that can work if you're, quite good at it and the patient and the provider that you're teaching are all in the right space. But this is fraught with a lot of errors. And it's particularly more challenging when we're working in a higher acuity or harder to execute procedure. That would be like someone just saying, here, I'm Michael Jordan. Just play basketball the way I play basketball. Do this dunk the same way that I do. Jump, 10 feet high, 15 feet far, etc. Interestingly, I did not notice this until making this post, but this is an edited image. This super famous image looks like it's been manipulated. I don't know if he's actually further away or closer to the basket than in actuality, but this iconic image isn't right. Look at the clock is there twice. The spectators are morphing into other people. So I don't know the true story behind this image. If anyone does, please let us know. But yeah, if someone asked me to do this type of move, no, I can't do it. I can't do it without setting up a structure, without teaching me the framework. And to be honest, at 5'6", I probably couldn't do it anyway. But for medical procedures, we can't just say, do what I do. We need to give people a framework. We need to give them a safe practice environment. And that's kind of what we're going to get into today. So our objectives for this talk are, we are going to explain how people learn new mechanical skills. We're going to understand the basics of that. Then we're going to figure out how we optimize the safety and efficiency of teaching skill instruction. We're going to apply several different practical frameworks for teaching procedures, and in the end, you get to kind of pick which one's your favorite. And then we're going to outline how to deliver high-quality performance feedback for people who are learning procedures. So teaching procedures is unique, right? This is unique compared to, say, a knowledge acquisition or teaching someone a knowledge-based skill because of several things. Of course, yes, there is knowledge involved, but there's more than that. There's a psychomotor skill component, and there's actually real-time decision-making, incorporation of visual, tactile, audio feedback, and things that are happening with the procedure, the patient's response to it, how we're doing with it, that need to be taught and mastered, which is just very different than learning a specific antidote or how to interpret an EKG. The stakes here are very high. They're high stakes because we have to consider and balance patient safety. There's going to be learner anxiety. And then we as instructors have responsibilities for all of that, which really ups the ante when it comes to teaching procedures, particularly in the clinical environment. And then there's a huge degree of variability. Now, we know with learners, there's degrees of variability about knowledge base when we're talking about knowledge translation, but learners differ widely in their experience and exposure to a procedure, their confidence, their aptitude and dexterity, and that high variability can make things really challenging as well. So our goal here is just to balance supervision, autonomy, and safety. That's what we're trying to do. We're trying to create a nice balance between supervision, autonomy, and safety. So a little bit of medical theory and educational literature here. There are stages of skills acquisition, and there are 3. I've added 1, but we want to kind of break this down and think about how people learn mechanical skills. So the first one is the cognitive stage. The learner basically understands the steps of the procedure itself. After they build this foundation or build the track on which they're going to run, then we have our associative phase. The learner gets to practice the procedure with coaching. They get to drive the bus or drive the train in our analogy. And then the third stage is this autonomous stage where the performance by the learner becomes fluid. They start to get skill. They have their aha moment. Reference our prior discussion about learning curves, but people start to get better and smoother with time during that autonomous stage. And then I added, of course, I'm big on cognitive science and keeping skills up. there's the maintenance stage. We all have to periodically revisit procedures to make sure we're staying sharp in them. So before we go further into some of our frameworks, let's just take a quick pause and recognize McCluskey. So McCluskey has the theory of margin. And really what we want to recognize here is that not every procedure and not every time is the right time to teach. McCluskey got into the idea of load versus power. And I think about this like an electrical circuit. Load is the resistance, power is the amps of the battery. Load are things that are negatives. They're keeping us from being in a place where we can learn properly. There's external pressures like family or community, internal like aspirations, desires, impress your attending, impress your colleague, personal goals of getting, the right sub-I, et cetera, et cetera. And then power is the opposite. Powers are things that allow us to learn. They are also external or internal. We got family support, we got work flexibility, we got a supportive work environment, and then internal, right? Resiliency, feeling healthy, having a lot of internal motivation to nail this procedure. And most importantly, what we're saying here is sometimes the load is going to be way more than the power. And that is not the time to teach a procedure. When the power outweighs the load, that is the time to teach. All right, so with that in mind, let's think about or talk about how we set up our learning environment. First, we're going to talk about the non-clinical environment. And there's a few things to balance here. We have to balance safety. We have to think about safety. We have to create a milieu of psychological safety and inclusivity. We have to have a learner who feels safe to ask questions, to admit that they don't understand something or that they're confused, to share ideas, and then make mistakes, right, without fear of being judged. And this welcomes diversity and perspectives and encourages collaborative learning and is just great all around. So we want to create an environment of psychological safety. Next, we want to create a structure. Now, we want to have a clear structure, but one that has flexibility for autonomy. So in the non-clinical learning environment, we want to set up really clear and defined objectives and expectations and kind of like, a scaffolding, if you will, for what we're going to be doing. We want to have that structure, but without rigidity. We want to have enough autonomy for the students to explore their interests, their self-directed learning, and allow them to be creative, to do some creative problem solving. And this sort of balance here really improves the motivation and the ownership of the learning, which we all know is super important for adult learners. And then we have to have the application, right? We all know, again, for adult learners, we and our students do best when they apply. So the ideal environment, it prioritizes hands-on practice and experience, simulation, spaced repetition, and ideally opportunities for self-reflection as well, right? If we think of Kolb's learning cycle, we have a defined experience. We're going to digest that experience. We're going to experiment with it. And having that time for that is really important. So if you're teaching procedures or teaching a skill, as an example, rather than having an hour and a half for suture workshops, having 3 30-minute sessions allows for that time in between for the adult learner to do some of that self-reflection and then come back with some ideas for experimentation and improvement. Creating context around this teaching in the non-clinical environment, also super important for the adult learner. And then finally, of course, we have to do feedback, right? We want regular, specific, and actionable feedback for our learners, which helps them to sort of calibrate their performance and then build their own sort of professional identity and how they're doing in the procedure itself. So with that in mind for a non-clinical environment and creating an environment for learning, now let's start talking about some of the frameworks that we can use to build out our procedural education. The first thing to know, this is from the Burgess article, which is in the show notes. These are sort of the 3 areas or components that come into skill competency. And I include this just because it's not necessarily what I would intrinsically think. They note that there has to be knowledge. Obviously, we recognize they need to know the indications and contraindications and materials and complications that might happen. But then they include, importantly, communication. So the learner has to be able to communicate effectively with the patient, with the nurse, with ourselves. They have to be able to get informed consent. And then they have to make sure that they maintain the patient's comfort and dignity when they're doing the procedure. And then finally, the big one, the one that we're going to focus a lot on here, is the performance of the skill. They need to be able to execute the skill and show the dexterity to do so. So with these 3 ideas in mind, let's start talking about some of the frameworks that are out there in medical education literature. So the first one is by Peyton, and this was an article published in 1998, and it is the 4 steps. So for this, we have demonstration. In demonstration, we, the preceptor, go through and run through the procedure start to finish at normal pace with minimal or no talking. We basically demonstrate how the procedure is done properly. Then we have deconstruction. In this one, the preceptor performs the procedure again, this time breaking it down into smaller, more manageable steps and explaining the steps as they go through. Then we have comprehension. This is where the student verbally explains the procedure and walks through the steps, demonstrating their understanding of these steps. This is sometimes called reconstruction or rebuilding it on the learner's behalf. And then finally, there's execution or performance. The student performs the skill either with direct supervision or independently while we observe them and provide feedback for them. So that's Peyton and the 4 steps. Then we have George and Dotto, who in 2001 went, spinal tap level, went from 4 steps to 5. And these are interesting, similar, but we'll talk about it. So step 1 here, they added this idea of conceptualization. This is where the learner basically learns the how and the why and the materials, the sort of pre-learning or building a foundation for the procedure itself. Then there's visualization, where they are seeing it being done by us. And then verbalization, where we as the preceptor hear or describe the steps as we do it in a broken down fashion, much like the Peyton way. And then the learner's recitation, so they're describing the steps in detail to us, and then they get to practice or perform it. So it's interesting that this article was published. If you kind of compare and contrast this and Peyton, basically what they added here was the conceptualization. Otherwise, visualization, verbalization, recitation, and practice are the same as what Peyton outlined. Then we have Sawyer. Sawyer in 2016 said 4 steps isn't good enough. 5 steps isn't good enough. I want 6. We need 6 steps for this. So step 1 from Sawyer is to learn. The student gets the foundational knowledge for the procedure, basically through study, watching videos, reading articles, seeing stepwise breakdowns of the procedure. Then they see it. So the learner sees us perform the procedure by us, the expert, in a step-by-step demonstration. So this is a little different for Sawyer. They don't have the do it without talking and then break it down. They just say see. So you can do it in either way, but going through it from start to finish, either quietly first and then broken down, they want to see the step-by-step processes. And then practice. So the learner gets to practice the skill in a safe environment. This is often on a task trainer or a simulated environment with us ourselves or a partner, and we are trying to give formative feedback from to the student from us, the instructor. So they practice the procedure in a safe space where we can give them feedback. So after practice comes prove. So after that, they show that they have competency in the skill by performing it again in an evaluative way. So this is with a simulated patient or with a task trainer. They are proving that they can do the steps, and that basically is done before they are allowed in many ways to do the procedure on a patient with direct supervision. So their autonomy is increasing here, and they're moving more toward that entrustment threshold. And finally, again, Sawyer, love it, the maintain, recognizing that learners need to maintain their skills through clinical practice, spaced repetition. So whether you think of it in 4, 5, or 6 steps, they have very similar elements to them about how we should be teaching these procedures to learners. So moving from the non-clinical learning environment to the clinical one. This is a big step, right? The student, especially if we're thinking about medical students, they are now performing the procedure in the clinical environment with people throwing shade like these, clinicians here with their very skeptical faces. There's definitely a change in the ante. There's a higher level to this. There's definitely going to be more stress when we come back to McCluskey's, load and power. So we have to focus on the learning environment, and the clinical learning environment, pay very careful attention to the idea that this is a higher stress situation. So what do we do to make this as ideal for the learner as possible? I like to think of just before, during, and after. Keep it simple, break it down that way. So in the before, we should do a quick learner self-assessment. Have you ever done this procedure before? What parts of this have you done? What has gone well? What has gone poorly? Then we're going to agree on the level of supervision. I am going to step in if X, Y, or Z happens. I'm going to step in if you fail to cannulate the jugular vein 3 times. I also like to just at least set up the idea of sort of safe words or phrases that can be used on either side to show a need for intervention from the preceptor. This can be, something like, I'm going to say, let me take the lead for a moment, or something along those lines. If I may, and I touch your hand, that means I'm going to guide you in a more appropriate direction. So my safe word is going to be, let me take the lead for a moment. If you would like me to intervene or step in for you, you can simply ask a question or say something like, I'd appreciate some guidance on X, Y, or Z. What's your next preferred move here? So in giving the learners an out, giving them the opportunity to communicate a desire for us to be engaged, involved, or physically hands-on without revealing themselves to the patient or whomever else is in the room is a nice thing to set up before you enter the room. So what do we do during? So of course, we're going to maintain calm. We're going to have some anticipatory cues, so set them up and be ready for the next step for them. If at all possible, we want to use hands-off guidance. Rather than taking the ultrasound probe, we want to verbally instruct them and guide them through the micromotions to get that parasternal long axis view. And then we're going to provide real-time adjustments, micromotion changes, trying to be conscious of or avoid overloading the learner during this time. And then finally, after procedure, we're going to do a short debrief. We're going to reinforce the things that they did well. And then ideally, we identify 1 or 2 focus areas for them to, change or improve upon next time. You might say, Jason, this is all good. This is all well and good, but sometimes the acuity is there. Sometimes the stress is high. This very sick gentleman whose heart rate of 40 being bagged is rolling down, and we have to do just a real-time procedure. We don't have time to set all those things up and make the milieu nice and all those things. So how do we instruct through procedures in that type of clinical context? Well, we have to have a plan. So we want to have a structure for what I call just sort of ad hoc bedside procedures, ones where you can't set things up, talk things through, set up safe words, all that stuff I already mentioned. And there's a few different ways you can do this, a few different structures. One I like is prepare, perform, perfect. So in this prepare, we're going to briefly review the procedure, the anatomy, the steps, and then say to them, we're going to set some expectations. You're going to talk through this, you're going to say the step, and then you'll perform it. And then, of course, we want to confirm that, the patient's set up right and we have the right equipment. So that's prepare. Perform, the student performs the procedure and they verbalize the steps as they do them. And you give, guidance and micro corrections, things like, yeah, perfect. Angle your needle tip just a little bit slower, advance slowly, find your needle tip. And, we want to try to keep our commentary short and concise here. And then perfect. We want to do immediate feedback, giving them one thing that they did well, at least, and then 1 or 2 things that they can improve upon. Another structure for this is just the see one, speak one, do one. In this way, the instructor is just going to perform or demonstrate the procedures, at least the key maneuvers, with 2 to 3 really clinically critical steps. We're going to walk through it very quickly for them. And then the learner actually goes through and speaks it aloud. They speak the sequence back to us in their own words, giving us the opportunity to correct some misconceptions before they actually go in and do it on the patient, and then do one. The student performs the procedure with graded autonomy depending on how they're doing. So that's see one, speak one, do one. And then the last here is the demonstrate, guide, observe, correct. This is a process you can do more so when you have iterative exposures with a learner. So if you're teaching a new PA how to do an ultrasound guided IV and you're going to do it several times, this is a great structure for that. So demonstrate, show the student exactly how the procedure should be done. That's pretty simple. Guide, then we're going to have the student perform this procedure with our real-time coaching. So you're going to do that procedure. And then observe. Next time, we're going to let the student do the procedure more independently with me simply watching. And of course, correct. We're going to give actionable feedback based on the observations we had. So demonstrate and guide them through the first 1, 2, 3, depending on the procedure. Then we observe them, and then we, of course, correct or give feedback. Always, always, always. So this is where, I call this slide the sure but why. Sure but how. This is where, I like to take medical education literature that I read, and I just like to take it and make it really applicable. Sometimes these ideas of like the 4 steps, the 5 steps, how to do feedback, those types of things are great in theory, but how do we actually brass tacks do these things in real life? Well, the first thing to recognize is that you don't need to reinvent the wheel, right? All of the procedures that we are going to be teaching have been thought about, constructed, deconstructed, reconstructed time and time again. And so we can take checklists and steps and other processes that are out there, and we're going to break them down and group them into digestible groupings like we see here for airway management. And then I also like to take any procedure that we're doing and think about macro, high level, big skills and micro skills and really target and hit these for the procedure itself. And then coming into this general idea of practicing and doing a procedure right or well, I don't think Vince Lombardi knew he was describing deliberate practice when he said practice does not make perfect. Only perfect practice makes perfect. But that is exactly what deliberate practice is. It is focused, purposeful, and systematic in its approach. And it's really goal-directed and feedback-driven. Rather than do a central line 15 times again and again and again, let's do a central line where the first 5 times we are absolutely optimizing patient positioning and the setup of our procedural field. The next 5 times, we're going to really focus on our syringe manipulation and needle tip management. And the last 5 times, we're going to really, really nail getting our guide wire in and not kinking the wire. So again, goal-directed, observed, and feedback-driven. And when we do repetitions, we do them with specific goals in mind. And keep in mind that feedback is going to be targeting technique, not just outcome, right? So if you have a beautifully plump IJ, you get the IJ in, great. We're not going to give feedback. Good job, you got that IJ. We're going to have targeting on technique. You fumbled a little bit in your equipment. Trying to have it outlined more succinctly is going to make that procedure easier when the patient's anatomy is harder. All right, and then assessment. So how do we complete assessment of these learners who are doing these procedures? So how are we going to assess the learners in these procedures? Well, I actually like to think of assessment with milestones and very specific markers. Really, our goal collectively is that our goal for education is that a student or clinician is able to practice medicine independent of supervision. And if we have that milestone in mind, it gives us a better true north when we're assessing these procedural skills. Now, this is Miller's pyramid, which I appreciate. It kind of breaks down procedural competence into different tiers, right? I understand the procedure. I know how to do it. I can show you how to do it. And then I can do it on a real patient, right? I get it. I know how to do it. I could show you in a trainer. I could show you in a real patient without complications. So baseline level all the way through execution. Interestingly, on this Miller's pyramid, they have competence here at the knows how and performance here. I don't understand that at all. Personally, I think competence and performance are the same, right? Being able to perform the procedure is being competent at the procedure. So for me, that is does. That is the goal. That's our milestone for when we're doing these assessments. And, recognize again that the same frameworks that we used to create our teaching structure and scaffolding for this can also very likely be used for assessment, as we saw here again with our airway management algorithm. And then finally, we have to talk about feedback, right? Feedback on a procedure really should require a structure because it's very hard to do it well every time. And there's so many different ways to structure your feedback. It's almost nauseating, but I have a few here which I think are helpful. One of which is strength, question, suggestion. So as you might imagine, strength, you're going to outline one specific thing that you think the learner did really well. The question is then we're going to ask the learner to identify what they think went well, and more specifically, what they think could be improved upon. And then suggestion, we're going to offer 1 to 2 specific behavior-focused ways for them to improve for next time. And then the next is ask, tell, and ask. So we're going to ask the learner how they think the procedure went. Tell, we're going to give them 1 positive, 1 reinforcing point, and 1 improvement point. So the tell plus minus. And then we're going to ask the learner to restate what they think the next steps might be or how they're going to improve for their next try. And the third way to give at least formative feedback is the arch style. So this is asking the learner for self-assessment. Then we're going to reinforce the things that they did well. We are going to confirm areas needing correction. And then we're going to help the learner develop an improvement plan. So ask, reinforce, confirm, and help. And then if you're giving summative feedback, another nice structure for that is Prime Plus. So Prime Plus is an acronym. It was actually RHYME initially, and they added the P. P is professionalism. I think for procedures, it's like, are they attentive to patient safety, patient comfort? Are they explaining the procedure thoroughly? Are they, approachable and able to work with the patient who's having the procedure performed on them, as well as their interaction with us during the procedural execution. And then the RIME is actually different levels that you graduate through. So the first is reporter, which is basically you can reiterate what is being said. Investigator, someone that can manipulate the information. Manager, I can do these things. And then educator, I can teach others to do it. And the plus is, of course, for next steps. What are we going to do to move ourselves from that reporter, investigator, manager, educator? So all of these structures can be used. Just find one that works well for you. Collectively, when I'm teaching, I use a lot of keep, stop, start, which also can be used here. It's similar to strength question suggestion. But as long as you have a structure and framework, using that routinely is going to help make the feedback much, much better. All right, so again, teaching procedures is a unique skill. It is something that we do intrinsically so often in medicine. And again, even if you're not in academic medicine, you're teaching people how to do things all the time. Teaching a new tech how to apply a thumb spica splint. As I mentioned, teaching our APPs how to do ultrasound guided IVs. There's a lot of tactile skills that we teach all the time. So take some of the show notes from this podcast and think about how you're going to approach the education of your friends, colleagues, students, learners, and even yourself as you move forward through procedural competency in emergency medicine. All right, guys, thank you so much for listening. Until next time.